Here we are at the final lecture in clinical chemistry. This is clinical chemistry 3. Here we go. Electrolytes. Electrolytes are negative ions or anions or positive anions or cations. They're found in all body fluids and they function in the maintenance of water balance, fluid osmotic pressure, and normal muscular and nervous functions. These are extremely important. They also maintain and activate several enzyme systems in the acid-base regulatory system. So just know electrolyte imbalances can throw everything off, so it's really, really important that they be in balance, and that's why we measure them. What is acid-base balance? Well, it refers to the steady state of the pH in the body. And I know I've mentioned before that the pH range in the body has to be very specific in order for things to work, for our enzymes to catalyze reactions, and for our metabolisms to work. So pH and acid-base balance, very important. Every change on the pH scale of one number is a power of 10 difference. It's exponential, right? So that's huge. So that means there's a power of 10 difference in the concentration of hydrogen ions in the body. So that can easily throw things off. Normal pH is about 7.35 to 7.45 for most of our mammals that we deal with. If the pH falls out of this range, proteins are actually diminished or destroyed. They don't work. So below 7.3 is considered acidosis. We have too much hydrogen. Too many hydrogen ions, and then above 7.4 is alkalosis. We have not enough hydrogen ions in the body. Here's our pH scale in case you have forgotten, and I'll just point a couple of things out here. Up here is our acidic range, the red, so that means we've got lots of hydrogen ions. And our pH is very low, so very acidic things, gastric fluid, somewhere between 1 and 2. Lemon juice, vinegar, all this stuff is around 3. So then we get into our neutral territory, distilled water, and then we go down here where we have increased concentration of hydroxide, and that is our high pH range. So alkalotic things, so alkaline stuff, milk of magnesia, ammonia, that sort of thing. Buffer systems in our acid-base system counteract imbalances by altering the hydrogen ion concentration in the body. These systems work both intracellularly and extracellularly. Both respiratory and renal systems work to regulate the pH in acid-base imbalance. Respiratory system can actually alter the acid-base balance, change the pH within minutes. Very important. Renal sometimes I might refer to as metabolic, so kind of everything else in the body, primarily kidneys, it can take days for them to really restore the pH balance. Acidosis versus alkalosis. So this is always categorized by the cause. We can get respiratory acidosis or alkalosis. So that means the respiratory system has some sort of abnormality going on that's causing it to create the body and the bodily fluids to be either acidotic or alkalotic. Then we have our metabolic acidosis or alkalosis, which is kind of any other cause other than the respiratory system that's changing our pH or our acid-base balance. Both of these systems can work to correct imbalances. Metabolic can correct respiratory and vice versa. If the respiratory rate decreases, less carbon dioxide is eliminated, so we get hypercapnia. So breathing slowly, carbon dioxide starts building up in the body, we get an increase in partial pressure of CO2, which is acidic, and we get acidosis, sorry. If the respiratory rate increases, we get hypocapnia, decrease in the partial pressure of CO2 in the body, we get alkalosis. Any metabolic condition that results in the buildup of acids in the body will obviously result in an acidosis. So big one, ketones, produced when the glucose metabolism is abnormal. Most commonly we see that in the context of DKA in animals or ketosis in cattle. And we get a decrease in bicarbonate levels. Vomiting can actually cause alkalosis because we lose a lot of our hydrogen ions that way out of our stomach. So it can cause alkalosis, can increase blood bicarbonate levels. Here are the electrolyte assays that we use all the time in practice. So I would say most of our blood profiles are going to give us sodium, potassium. A lot of them give us calcium, magnesium, and hydrogen as well. Anions, we almost always get our chloride. And then we can get our bicarb, phosphorus, that sort of thing as well. So what are some causes of changes in electrolyte concentration? Well, obviously we can have increased or decreased intake. So maybe an animal's not eating or drinking properly, so they may have a decreased intake, or maybe they're eating something that they shouldn't normally and they're getting extra electrolytes that way. Who knows? We get shifts of electrolytes between the extracellular fluid and the intracellular fluid, so that's going to change what's going on in our bloodstream. And there's increased or decreased renal retention because our kidneys can kind of choose to a point what they're going to excrete. So that can change our electrolyte balance. Arterial samples are ideal for analyzing electrolytes and blood gases. They're harder to get. They're certainly not done every day except potentially in referral practices, but these are great ways to look at electrolytes and blood gases. You have to analyze them right away as soon as you get these samples. Sodium. So this is the major cation of plasma and the extracellular fluid. It has a really important role in the distribution of water and body fluid osmotic pressure maintenance. I know I've talked in previous lectures about osmotic pressure. The most important example of that is keeping the osmotic pressure within the vasculature high so that fluid stays in the bloodstream, and that keeps our blood pressure up. Hypernatremia just means elevated sodium, and hyponatremia is decreased sodium. If you use heparin, you can get falsely elevated sodium results, just so you know. Some conditions associated with altered sodium concentration, you can see that here. Water deprivation is going to give you high sodium, hyperventilation, osmotic diuresis. Hyponatremia, when do we get low sodium? GI disorders primarily. And again, ketonuria, we're losing ketones. Addison's disease and congestive heart failure sometimes. So there you go. Potassium. Potassium is our major intracellular cation. It has so many different roles. It's important with normal muscular function, for respiration, cardiac function, nerve impulse transmission, metabolism of carbohydrates. So what happens? How do we get hyperkalemia? Well, potassium leaves the intracellular fluid and elevates the plasma heparin potassium levels. With hypokalemia, we have decreased potassium levels because of inadequate potassium intake or alkalosis. So alkalosis drives potassium into the cells, so we get low potassium levels in the blood. Fluid loss from vomiting or diarrhea. So plasma is preferred to test potassium because it can be released during clotting. Avoid hemolysis, because hemolysis again will release potassium. Anything that potentially damages cells can release potassium and give us falsely elevated potassium results. What causes hyperkalemia? Metabolic acidosis. So acidosis causes potassium to move out of the cells. So that'll cause hyperkalemia. Urinary tract obstructions, renal insufficiency, so it's not getting removed properly from the body. And then we have hypokalemia, which happens obviously with anorexia because the animal's not taking in the potassium they need. Ketonuria, again, diuresis, same sorts of things as we see hyponatremia with. Chloride. So here's our extracellular anion that we deal with every day. It plays an important role in maintaining water distribution, as we mentioned before, with sodium, osmotic pressure, and the normal anion-cation ratio. Since this is our primary anion, this is the one we talk about the most, so it's really important with that anion-cation ratio. Hyperchloremia obviously is elevated chloride levels. Hypochloremia is decreased chloride levels. What can interfere in chloride results? Well, hemolysis can. So be careful if you have a hemolyzed sample. Chloride has to be taken with a grain of salt. And prolonged storage. Prolonged storage can change chloride results as well. Here's an automatic electrolyte analyzer. This happens to be the Vetlite by Audex. I would say less commonly used now. A lot of the general biochemistry machines actually include electrolytes now, so a lot of clinics don't have a specific machine for electrolytes anymore, but certainly I've worked in several practices where Vetlites and similar things like that have been used, so you may see them. So what have we learned about electrolytes? Well, sodium, potassium, and chloride are the ones we really seem to look at the most in clinic. Some electrolyte analyzers can also evaluate things like calcium, phosphorus, magnesium, bicarb, blood gases. These are really, really important, especially in emergency situations. So a lot of emergencies hospitals will have these. And again, the best thing to do is to do these samples, run these samples with arterial blood. The major electrolytes of plasma are calcium, phosphorus, magnesium, sodium, potassium, chloride, and bicarbonate. Changes in electrolyte concentrations have lots of causes, as we've talked about. Let's talk about a few more miscellaneous tests that you'll see all the time in clinic. There are all kinds of other assays that can be performed in veterinary medicine. Many of these are designed to detect abnormalities in the endocrine system, or there are some other biological tests that are not specific to an organ or system, but are more general, but they're still diagnostic or prognostic, so they're really important for those reasons. Many of these tests may need to be sent to a reference laboratory. So we're getting into that sort of field where you likely won't be running these on your machines, but you will be sending these away frequently for your veterinarian. Creatine kinase, CK. This is one that actually goes against what I just said. Creatine kinase is one that's tested for fairly frequently in clinic, but of course shows up on a lot of referral blood work as well. It's primarily produced in the striated muscle cells, but also a bit in the brain. It is one of the most organ-specific enzymes available for clinical evaluation. It leaks out of damaged muscles into the blood. It's impossible to determine, though, which muscle is damaged or how severely it is damaged. All we know is that some muscle has been damaged and the CK has gone up. You can get artificial elevations if your sample comes into contact with bleach, EDTA, fluoride, light, any delay in running the test. So CK, I'd love to tell you it's really, really useful. I find most of the time it's really, really not. Some animals you can just do, if there's a hard blood draw, they can get enough CK released just from the blood draw itself that it's going to be elevated, and it really doesn't tell you very much. So that's just to let you know what it is. It can be useful in certain muscle disorders and things. I would say not one of our best tests in practice. Lactate. Lactate is that stuff that builds up in your muscles when you're running really, really hard or whatever, and you get the horrible pain in your muscles. That's lactic acid. It's being produced by anaerobic cellular metabolism. Its presence doesn't indicate a specific disease, but what it does indicate is that there's hypoperfusion or hypoxia of that tissue. Increased levels can be found in plasma, peritoneal fluid, and CSF. Normally, samples are usually collected in fluoride oxalate or lithium heparin tubes. Lactate is typically run, I'll give you the one example of where we run it the most, saddle thrombus cats. So your cats who come in can't move their hind legs, you're not 100% sure if it's maybe a spinal cord damage or something, or maybe it's a saddle thrombus from heart disease. If you're not sure, you can actually take a blood sample from a front leg, a blood sample from the back leg, take lactates on both and compare them, and if the lactate in the back legs is elevated compared to the front legs, then you've probably got a clot, so you've probably got a saddle thrombus. And that's where we use it most often. Here's a handheld lactate meter. Most clinics don't have these. Emergency clinics often do, but very, very handy to test for lactate. Now we'll get into some endocrine system assays. There are so many of these. They are almost all ones that you'll send away, though there are some that can be done now in clinic. Let's start by talking about adrenocortical function tests. They are very commonly performed. So we're looking at the adrenal glands essentially here and their function. Dysfunction is really, really common. We see it all the time in practice. Why? Well, there's at least in part because we misuse steroids. Corticosteroids get overused a lot in practice, or they're used appropriately, but in animals where there are alternatives that are just more expensive. So that's why we don't end up using the alternatives. So remember, the adrenal axis starts with the hypothalamus. It's kind of the boss. When it is stressed, the brain triggers the hypothalamus to secrete corticotropin-releasing factor, or CRF. Then CRF in turn will trigger the adenohypophysis to secrete ACTH, which is adrenocorticotropic hormone. And then cortisol is released as a result of that from the adrenal gland. It feeds back to inhibit CRF and ACTH release, and then that makes it a balanced system. So the adrenals produce the cortisol goes back to the brain and says stop producing CRF and ACTH. Great, everything regulates itself. So brain or pituitary tumors and overuse of glucocorticoids can cause excessive cortisol release and therefore Cushing's disease, which is hyperadrenocorticism. As you might remember, Addison's disease is the opposite of that. It is hypoadrenocorticism, and that's a decrease in blood cortisol. How do we diagnose these? Well, it takes more than just a single measurement. We need baseline data on these animals, and then we need to challenge the animals and see how they respond, which is what we do with an ACTH stimulation test. So for animals with suspected Addison's or Cushing's diseases, then we can use ACTH, exogenous ACTH, so basically an injectable form, and evaluate the blood levels of cortisol before and after we give it. The degree of the response is proportional to the gland size and development, so it helps to distinguish between iatrogenic and spontaneous hyperadrenocorticism. So if you remember what iatrogenic means, that means that we basically caused this in the animal. So iatrogenic Cushing's disease happens when we give too much steroid, and so they have a high level of cortisol as a result. Spontaneous hyperadrenocorticism means that the animal itself is just producing too much cortisol. ACTH stim test is a screening test. It is about 80% accurate in dogs and unfortunately only about 50% accurate in cats. Then we have dexamethasone suppression tests. It's a low-dose dex test we use to confirm the results we get with ACTH because, like we said, 80% accurate on dogs, 50% cats. So if our ACTH stim comes back supporting hyper or hypoadrenocorticism, then maybe we'll run the low-dose dex test, especially if we're looking for Cushing's. And this can actually, or we can actually replace the ACTH test with the low-dose dex test. High-dose dexamethasone testing also happens. It's better at differentiating pituitary from adrenal causes of hyperadrenocorticism. If we're looking at cats, only a high-dose dex test is really suitable. So when it comes to dexamethasone suppression tests, there's about a 73% accuracy in differentiating pituitary from adrenal causes in dogs and about 75% accuracy in cats, or sensitivity, sorry, in cats. Thyroid assays. So thyroid hormone influences a bunch of things: metabolic rate, growth, and differentiation of all body cells. So very important, obviously. The thyroid glands are governed by adrenal cortices. Thyrotropin releasing factor, TRF, actually triggers the release of thyrotropin, or TSH, thyroid stimulating hormone, the one we're more familiar with. And then the TSH in turn will enhance the growth of the thyroid function, and of course how much thyroxine is released from the thyroid gland. So thyroxine, either T3 or T4, actually completes this whole cycle by going back and inhibiting TRF and TSH when there's enough of it in the bloodstream. Thyroid disease is primarily hypofunction. So we get hypothyroidism in dogs, horses, ruminants, and swine. Cats get hyperthyroidism. There are only a very few exceptions to this, and that's usually just iatrogenic, meaning we've overtreated either the hypo or hyperthyroidism. What causes these conditions? Well, dietary iodine is a huge factor in the production of thyroid hormone. So, increased or decreased dietary iodine, so increased or decreased intake of dietary iodine, can actually cause these conditions. Primary gland disease can do it as well, so it could be a congenital thing or something that's just developed within the gland itself. In-house testing can be performed now with immunologic methods. There's T4 and free T4 that you can do in clinic. However, I would say that most people still send these away on a routine basis. Certain drugs might decrease T4 levels, and in hypothyroid dogs, you'll see a decrease in total T4 as well. TSH response, this is a test that's used in small animals and horses, but not in cats. It's a reliable diagnostic separation between normal versus abnormal thyroid function. So say you get a thyroid test back and you're looking for just T4 and it's low. Well, you don't know why it's low. It could be low because something else is going on. This happens all the time. It's called euthyroid 6 syndrome. So maybe a dog has really low T4, but that's because it has, horrible skin disease going on, or it has some other illness that's actually suppressing the thyroid or causing low thyroid levels. We don't know if this is a primary problem or not, just based on the total T4. So what we'll do often is send away a TSH at the same time. So we'd measure the thyroid stimulating hormone. And the thyroid stimulating hormone should be really, really high if the thyroid hormone is low, because the thyroid stimulating hormone its function, of course, is to stimulate the thyroid to produce more thyroid hormone. So if our TSH is low and our thyroid hormone is low, well, this is not primary hypothyroidism, because the TSH is not begging the thyroid to produce more thyroid hormone, so something else is probably going on. However, if the TSH is really, really high, then that is indicating that the body is trying to produce more thyroid hormone and just can't. So that's a primary hypothyroidism. So again, in normal animals, we give TSH, and then we get an increase in serum T4, and exhausted or insensitive thyroids just don't respond to that. TSH and ACTH tests can be run together if there's suspicion of potential Cushing's as well. TRH, we don't use very much. TRH response, thyrotropin releasing hormone. Its use on small animals does provide a reliable diagnostic separation of patients with normal versus abnormal thyroid function, but again, we tend to use TSH most of the time. So I'm just going to move on to GI function. So there are a few chemical tests that we do use for gastrointestinal function. As we know, the principal function of the GI tract is to assimilate nutrients and excrete waste. Most nutrients are ingested in a form that's actually too complex or insoluble for absorption, and our GI tract kind of takes those, solubilizes, degrades things enzymatically, and turns them into simple molecules that can be absorbed and used. GI diseases are common, very, very common, and anyone who spent any time in a small animal hospital knows how common, especially in the summertime. Specific diagnosis is essential for properly treating GI tract problems. However, I would say a lot of the time we kind of skip over the definitive diagnosis of GI tract a lot of the time it's because we need biopsies, and a lot of people don't want to go there. I mean, it's complicated. It involves general anesthesia. It involves minor surgeries, usually sometimes more invasive surgeries. However, function tests can be performed as well to confirm the need for more invasive tests. So before we go to the biopsy, we can do some function tests, and that's what we're going to talk about. There are two classes of malassimilation to talk about as well. So there's maldigestion, and that's altered gastric secretion and lack of or decreased digestive enzymes. There's usually about 90% loss of function of the exocrine pancreas before that happens. So it's actually kind of rare to see it. There's also malabsorptive GI disease, and this is an acquired disease of either the intestinal wall or bacterial overgrowth. I think we see quite a lot of bacterial overgrowth in our animals, and I'd say that that often causes malabsorption. We often see diarrhea and such with those guys, of course, as well. This is probably the most common function test that I will send away, and this is the folate and cobalamin, or B12. So we often call this the B12 folate test. It's an immunoassay that's done usually in an external reference laboratory. And if there's malabsorption, we usually get low folate and low B12. The folate itself is absorbed in the proximal intestine, and cobalamin is absorbed in the ileum, so more distal. And bacterial growth can alter concentrations, because folate synthesis actually can increase with this, and cobalamin decreases. So this can be a bit of a screening tool for your chronic diarrhea cases, for instance. Here's a note on toxicology. So toxicological emergencies, which is how they usually present, they require an accurate history, obviously environmental factors. What did this animal have access to? You need to do a thorough clinical examination, good physical exam, vitals, that sort of stuff, and diagnosis of these can be quite difficult. Personnel have to be familiar with these agents of these toxic agents and competent with their treatment. We need to make sure that if there's any testing that we're doing for toxicology, that our reagents aren't outdated, and we might need some special equipment depending on what we're testing for. Because of all these things, we don't tend to do toxicological diagnostic testing in clinic. These get sent to reference laboratories most of the time if we have to do them at all. So if you're handling toxicological specimens, consult with the laboratory first, because this is rare that we do this. You have to know how to properly handle them, package them, transport them, and they have to be free of contamination. Always label, I mean, this goes for anything that you're sending away. Always, always, always label everything. These samples that we send can be food, tissue, fluids, vomitus, and always have detailed records. There's often litigation involved, like, oh, my neighbor poisoned my dog, I don't know what he used, whatever. So always, always keep detailed records if you're dealing with toxicological specimens. There are some tests that can be performed within a veterinary practice lab. These are mainly screening tests, and again, usually we'll be sending these away to a diagnostic lab to verify our results. Anticoagulants and rodenticides, one of the most common toxicities that we see in practice. Warfarin probably being the most common, difascinone, pindone. They act by inhibiting the metabolism of vitamin K in the body. So vitamin K is required for the production of clotting factors. So no vitamin K, no clotting factors. So initially what happens is that the PT, the prothrombin time, is increased. Then the partial thromboplastin time, PTT, increases. And then finally the ACT, the activated coagulation time, is prolonged. The diagnosis can be based on these screening tests and response to vitamin K. So if we see an animal where there's suspected rodenticide toxicity, we can run PT, PTT, ACT, and then we can also give vitamin K and watch the response to vitamin K therapy, which usually is very good, by the way, if we catch it early enough. Chemicals that denature hemoglobin. So this is another thing that we see not uncommonly in clinic, unfortunately. So These chemicals can alter hemoglobin within the red blood cells, and they can form Heinz bodies. Cats, this happens most commonly, I would say, in cats. Acetaminophen, that's a big one. Methylene blue, yeah. But acetaminophen is probably the biggest one. People giving their cat Tylenol because, though the cat was limping, so I gave it Tylenol. Well, this can cause a hemolytic anemia. Dogs, onions, also cats. I mean, I've had cats come in with onion toxicities. So onions actually cause hemolytic anemia in dogs. Horses, red maple leaves. Interesting, eh? Ruminants, onions, and brassicas. So all these things that seem kind of benign to us can actually cause hemolytic anemia in our animals. Just a reminder about Heinz bodies. They kind of poke out of the side of red blood cells. So you've hopefully seen those before. So you can see that at the bottom there. And then ethylene glycol. This is another, unfortunately, too common toxicity. This is antifreeze poisoning. This is serious or fatal in dogs and cats. The problem with antifreeze, it's that coolant fluid in your engine, the green stuff, that sometimes you'll get coolant leaks or something like that, and maybe a cat or dog will come along, and the problem is that ethylene glycol is actually very tasty. It tastes sweet, so our animals are happy to lick it up. Well, again, this is serious or fatal in dogs and cats. Ethylene glycol and its metabolites can actually be detected in whole blood or serum if you send it away to a toxicology laboratory. Most of the time we don't have time to wait for those results, but it can be done. It's strongly suggested by looking at urine sediments. And if your urine sediment contains a large amount of calcium oxalate monohydrate crystals, there's a really good chance this is an animal with ethylene glycol poisoning, especially if they've had exposure to ethylene glycol or known exposure. Drugs of abuse. So very common that we get animals in that have been exposed to a variety of illegal and prescription drugs. I mean, it ranges everything from someone calling up, oh, my dog ate half a bottle of my pills, and then, now he's trembling and this, that, and the other thing. It varies from that type of call to the animals that come in just about comatose from getting into something. These animals don't tend to show up, especially if we're talking about illegal drugs. These animals don't tend to show up until clinical signs have appeared already. It's a very difficult thing to deal with because a lot of the time we don't have a specific history with these guys because clients are afraid of prosecution. Again, this is when we're talking illegal drugs. Clients do not come forward with that information, even if it's marijuana. Something that is a very, very common toxicity of dogs. That it's still people don't come forward and say, oh, my dog got into my weed. They're worried. They're worried you're going to prosecute them. Even if you tell them over and over and over that you're not there to do that, that's not your job. In fact, it's not our place at all to report things like that unless we're worried about animal abuse. So, very difficult. We have a lack of specific history. We have to kind of go with our best judgment. Sometimes people will eventually come forward and say, actually, my dog ate my pot brownies, and that's fine. And then we know to worry about chocolate as well. So clinical signs vary with drugs of abuse, obviously, depending on which drugs these animals got into. All right, what did we learn? Increased lactate levels means hypoxia and hypoperfusion. So again, think cats with saddle thrombus. ACTH and cortisol concentrations can be helpful in diagnosing adrenal dysfunction. Very helpful, actually. Thyroxine. There are two varieties of hormones, T3 and T4. Free T4 is the fraction of thyroxine not bound to a protein. That's the one that's actually the most useful test because free T4 is our active T4. In-house thyroid testing uses immunologic methods. So if we were to do a T4 in-house, often we use an ELISA test for that. And then ethylene glycol ingestion can be serious or fatal. Great, so that's it for clinical chemistry. Any questions? Give us a call or an email.